Welcome to this explainer. I am so thrilled you're here today because we are embarking on a really high-stakes clinical journey. We're going to completely master the administration of the BCG vaccine. Whether you're a nursing student gearing up for a tough practical exam or an experienced healthcare professional just looking to sharpen up those clinical skills, you are in the right place. We're going to break down the whole shebang, from the underlying science to the exact mechanics of the injection, right down to patient aftercare. So let's dive right in. Here is our roadmap for today. We'll be hitting 1. The BCG vaccine basics. 2. Who gets the vaccine? 3. Preparation and patient assessment. 4. The intradermal injection technique. 5. Expected reactions and post-care. And finally, 6. Avoiding common nursing errors. But hey, before we run through the checklist, I want you to think about this. A lot of you watching probably have a small, slightly indented scar on your upper left arm. How exactly does this tiny shot protect vulnerable infants from a deadly disease like severe tuberculosis? And why on earth does it leave a permanent scar that stays with you for life? Keep that in the back of your mind, because the answer lies in the really unique way this vaccine interacts with the human body.
Okay, let's kick things off with Section 1, the BCG vaccine basics.
So, BCG stands for Bacillus calmette-guerin, named after the two scientists who developed it. The absolutely crucial thing to know here is that this is a live attenuated vaccine. What that means is it contains a living but highly weakened strain of Mycobacterium bovis. Now, it's not going to give the baby the disease. Instead, it acts like a sparring partner, training the infant's immune system to fight off severe, life-threatening forms of TB, stuff like tuberculous meningitis and miliary TB. It's literally a vital shield for these infants.
Moving right along to Section 2, who gets the vaccine?
You really have to pay attention to the stark contrast here. On the one hand, our indications are straightforward. We routinely give this to healthy newborns, ideally within their first 24 hours of life, and to kids at a high risk of TB exposure. But, and this is a massive but, because it's a live vaccine, catching the contraindications is a matter of life and death. You absolutely cannot give this to patients with severe immunodeficiency, like those with HIV, leukemia, or anyone on chemo. It's also a strict no-go during pregnancy, or if the patient has a severe acute illness. Giving a live virus to someone whose immune system is compromised, yeah, that's incredibly dangerous.
All right, Section 3, preparation and patient assessment.
When it comes to the dosing math, it's a simple but unforgiving rule. It is entirely based on age. For infants under 12 months, the dose is exactly 0.05 milliliters. But the second they hit that 12-month mark or older, boom, the dose doubles to 0.1 milliliter. You literally have to double-check the patient's age every single time. Honestly, getting this wrong is an instant failure in clinical practice. Remember, under a year old gets exactly half the dose. Once your dose is confirmed, you follow this exact prep sequence. Step 1, verify your vaccine, the batch number, and that expiry date. Step 2, wash those hands. Step 3 is where people mess up. You must reconstitute the vaccine using only the specific sterile diluent that comes in the box. Never ever substitute it. Step 4, mix it gently. Don't go shaking it vigorously or you'll actually destroy the live bacteria inside. Finally, Step 5, draw your exact dose into a 1 ml tuberculin syringe and be super careful to avoid any air bubbles. Now for the main event, Section 4, the intradermal injection technique. Before we get into how to do the injection, let's talk about where. We always target the upper left arm, right over the insertion of the deltoid muscle. Why so specific? Well, it's basically a globally standardized map. If a doctor 10 years down the line needs to check if a child got the BCG vaccine, they know exactly where to look for that signature scar. You definitely can't just pick a random spot on the leg and call it a day. Okay, mechanics time. You've got the infant positioned comfortably. Step 1, gently stretch the skin of the upper left arm until it's nice and taut. Step 2, insert your short needle with the bevel facing up. Now you want a ridiculously shallow angle here, just 5 to 15 degrees. You're aiming to slide that needle just barely under the epidermis, the very top layer of the skin. Step 3, push the plunger and inject slowly. Because you're pushing fluid into such a tight, shallow space, you're going to feel some resistance, and that's exactly what you want. As you're pushing that plunger, you are looking for a very specific visual cue. You should see a tiny, pale blister pop up on the skin. We call that a wheal or a bleb. And you want the diameter of that wheal to be exactly 5 to 7 millimeters. Seeing that 5 to 7 millimeter pale wheal, that right there is your holy grail. It's your definitive proof that you nailed the shallow intradermal placement perfectly. Which brings us to the absolute golden rule of BCG. Once you gently pull that needle out, do not massage the site. Do not press a cotton ball hard against it. And whatever you do, no way, absolutely do not slap a Band-Aid or adhesive dressing on it. If you do any of those things, you'll literally squeeze the vaccine right out of that delicate epidermal space or force it deeper into the tissue. It ruins the whole procedure. Just leave it be. And that takes us to Section 5, Expected Reactions and Post-Care. Over the next couple of months, the infant's body wages a localized immune battle right there on their arm. On day 0, you've got that little wheal. A few weeks later, it swells into a small raised papule. By weeks 4 to 6, it actually breaks down into a small weeping ulcer. Actually, I know ulcer sounds terrifying, but trust me, it's completely normal. Finally, around the 6 to 12 week mark, it heals over and leaves that famous permanent scar. This whole timeline is just visual proof that the body is successfully building local immunity. Now, because a weeping ulcer looks super alarming to a new mom or dad, your parent education game needs to be top-notch. You basically need to tell them, leave it alone, keep the area clean during normal baths, sure, but do not squeeze the bump, no soothing creams, no harsh antiseptics, and again, no bandages over the ulcer. They just have to let the natural healing process do its thing. It looks a bit messy, but it's exactly what's supposed to happen. Finally, let's wrap up with Section 6, Avoiding Common Nursing Errors. Here's a quick rundown of the classic pitfalls. Giving it via the wrong route, like going subcutaneous or intramuscular instead of intradermal. Messing up that age-based dose, or picking the wrong spot on the body. But honestly, the most common physical error by far is injecting too deeply and blowing right past that epidermal layer. And of course, there's massaging the site, using expired vaccine, or forgetting to document the exact batch number and location. As a clinician, you also have to know when to sound the alarm. Mild redness, a small ulcer, some slight swelling, totally normal. But you must refer that patient to a doctor immediately if you see red flags. We're talking about a large, painful abscess, an ulcer that just refuses to heal after 12 weeks, a high fever, or, and this is a big one, significantly swollen lymph nodes in the armpit, which is called lymphadenitis. These severe complications are rare, but they almost always happen because someone injected the vaccine way too deeply. So let's do a quick pop quiz to test your troubleshooting skills. Let's say you've prepped everything flawlessly, you insert the needle, push the plunger, and nothing happens. No wheal appears on the skin. What went wrong? And more importantly, what are you going to do about it? Here's the deal. If you don't get a wheal, your angle was simply too steep. The needle slipped right past the epidermis, and you injected the vaccine way down into the subcutaneous tissue. But listen to me on this. Do not repeat the dose. Don't pull the needle out and try again unless your specific local clinical guidelines explicitly tell you to. Giving a second dose can trigger some really severe local reactions. You just document the error, keep an eye on the patient, and follow your clinical protocols. To bring this entire clinical journey home, I want to leave you with this core takeaway. A visible wheal of 5 to 7 millimeters confirms proper intradermal injection, and accurate documentation is essential for safe immunization practice. If you can master that tiny little wheal and you keep your paperwork flawless, you are going to provide incredibly safe and effective care. And that wraps up our explainer. Now that you've got a really solid grasp on the science, the strict prep rules, and the exact physical mechanics of giving the BCG vaccine, how are you going to use this clinical journey to totally crush your next OSC examination? Just remember your steps, visualize that 5 to 7 millimeter wheal, and you will absolutely master this vital skill. Thank you so much for hanging out with me for this deep dive, and keep on learning.